Good evening, one and all. Today I will be talking about live worm in retina with the diffuse unilateral subacute neuroretinitis. Approach to treat the live worm in retina with USN and the rationale for different techniques and their effectiveness. This is a case of a 66-year-old male diagnosed with elephantiasis of the left leg, presented with diminution of vision in the left eye since 4 days. The uncorrected visual acuity was 6/24, improving to 6/6 in the right eye, and 5/60, improving to 6/18 parts in the left eye. RAPD, that is, and color was present, and color vision was defective in the left eye. On the fundus photograph, disc edema with splinter hemorrhages with subretinal live motile worm seen with the wriggling movements in the macula was noted. You can see in photographs that the head end is moving, and OCT also depicts the subretinal worm. So we did focal laser to both the ends with a 532 nanometer argon laser with a power of 160 millivolts and a spot size of 200 millimeter, duration of 150 milliseconds. 5 spots were given. 3 days after laser, resolving disc edema with the dead worm was seen. Filaris is a common in India, and they exist as adult worms, elephantiasis, and embryos, microfilaria in the infected human host, transmitted by blood-sucking mosquitoes, Culex photogens. The endemic areas of lymphatic filariasis, that is Wucherer bancrofti, called as Malabar leg or Burgia malai, are mainly along the sea coast and the banks of large rivers. DSN is a clinical syndrome caused by motile white glistening non-segmented nematome entering the subretinal space. The worm has been recorded in at least 2 different sizes, 400 to 1000 micrometers or 1500 to 2000 micrometers. It is characterized by vitritis, papillitis, and recurrent crops of white evanescent lesions, followed by several visual loss, optic atrophy, narrowing of the major retinal vessels, and diffuse retinal pigment epithelium degeneration. The pathogenesis of DSN seems to involve a local toxic effect on the retina caused by the worm byproducts, rapid loss of vision, and progressive optic atrophy, secondary to death of the ganglion cells, may be a remote reaction to the immune toxin. The visibility of a motile worm is the gold standard in making the diagnosis of DSN. Oral hand health mix and antimicrobials are likely to be ineffective because of the relatively impermeability of the blood-retinal barriers, though it is recommended for those patients who have severe vitritis, where the worm cannot be easily identified. The use of scatter laser photocoagulation in the vicinity of the multifocal active lesions when the worm is not visible was also used. The BRB function may be altered by severe vitritis and laser photocoagulation, and that might modulate the drug entry to the neuroretina. The Th1 and Th2 immune response may be impaired during infestation and return to normal levels between the recurrent bouts of infection. So the serological studies for detecting the worm, analysis of the stool for OVA, and the hematological evaluation for eosinophilia are of limited value, despite persistent survival in the relatively immune-privileged subretinal space. The aim of laser therapy is to achieve the death of the worm without inflicting the collateral damage to the macula. IV methylprednisolone 1 gram for 3 days, followed by oral steroids 60 milligram and tapering over 21 days, with albendazole 400 milligram immediately and diethylcarbamazepine 100 milligram TDS for 21 days, along with topical steroids was started to control the inflammation caused by the dead worm. Patient came after 3 days with resolving DSN, and dead worm was noted with improvement in the visual acuity. So we conclude that DSN is associated with severe visual loss. Early identification and prompt destruction of the infecting worm by laser photocoagulation, that is the treatment of choice, can preserve the good visual acuity. A combination of laser treatment, systemic steroids, and antihelmintics is more effective. References are there. Thank you.
So the laser treatment is always required, or you can just manage with the steroids and anti-helmintics?
Yeah, first of all, live motile worm is very, if it is big, like as I told, only will be visible. Most of the times it is not visible. And if it is visible, gold standard is to do a laser unless and until it is located in the macula. If it is away from macula, we can always plan for a laser. And most of the times, as the live worm is not noted, so we go for alendemics and anti-inflammatory.
Unfortunately, in your case, you could.
Yeah.
You go back to that picture also.
How can you be sure that it was filariasis?
A patient presented with elephantiasis of leg also.
Right. I'm sorry, I missed that.
एक slide एक बार लगाना। ये भी slide एक बार लगाना।
So,
Very interesting.
so this is the head end actually.
And these are usually,
So you can-
these are not solitary, right? I mean, there will be many in the body.
Main in the body. Yeah, patient already had elephantiasis of left leg.
These are just that
if you had put that picture, it would have added more power to your presentation. The
left,
elephant
yes,
ears,
yes,
yeah,
yes.
that. And the post-op one, I mean the post-laser.
This the disintegrated worm.
Thank you.
Thank you, ma'am.